This video will present 4 scenarios from my corneal fellowship demonstrating different iris repair techniques used to restore iris anatomy. I hope this short course will provide practical guidance for future iris reconstruction cases. Case 1 shows repair of iris coloboma using the force-through pupiloplasty technique. A key surgical pearl is to divide the iris into 2 leaflets on each side with intraocular scissors. Then close the defect using tenno purling sutures to evenly distribute tension and minimize pupil ovalization. The suture is passed through the iris on a curved needle, guided out with a blunt viscoelastic cannula. A Coughlin hook is then used to retrieve one end of the purling to form a loop. False rolls are created in a loop. One end of the suture is grasped, and the knot is secured by pulling the opposite end. A second false-through pupiloplasty is performed in the same manner to fully close the iris defect, resulting in a well-centered round pupil. Case 2 demonstrates repair of traumatic mydriasis using the iris clutch technique. A tenno double-armed purling suture on curved needle is introduced through a paracentesis. The needle is passed through the peripheral iris in a bite and advance fashion, taking small, evenly spaced bites along the pupillary margin. We typically aim for 5 to 6 bites per quadrant. The needle is then externalized through the opposite paracentesis with a blunt viscoelastic cannula. The same maneuver is then repeated in the opposite direction using the second curved needle on the other end of the suture. The needle is passed through the peripheral iris, taking small, evenly spaced bites along the pupillary margin and advancing sequentially from one paracentesis to the next. The needle can then be externalized through an adjacent paracentesis to achieve a more ergonomic position, allowing the surgeon to perform subsequent passes with a better control and precision. The temporal quadrant of the iris is sutured using the same technique, taking 5 small bites along the pupillary margin. The process is then repeated in the superior quadrant. Once the suture has encircled the entire pupillary margin, externalize both ends through the same paracentesis. Then gently tighten the suture using a 3-1-1 knot configuration. After completing the initial 3 throws, internalize the suture and use a micrograsper to fine-tune the tension. Adjusting the pupil to the desired size while ensuring centration and symmetry. Once adequate tension and a round pupil configuration are confirmed, secure the knot and trim the suture. In this case, patient had an excellent outcome. Case 3 demonstrates management of a penetrating eye injury with traumatic aniridia. In this case, a prosthetic iris implant was sclerally fixated. A peritomy is first performed, followed by the creation of 2 scleral grooves positioned 180 degrees apart. The iris implant is trimmed to the appropriate size for patient's eye. A double-armed CV8 Gotex suture is pre-placed through the implant. The curved needles are straightened to facilitate passage and are guided through the sclera using a 25-gauge needle introduced via the already performed scleral grooves. This maneuver is repeated twice on each side, taking care to maintain proper suture orientation and avoid crossover. The prosthetic iris implant is then folded and inserted into the anterior chamber. Once satisfactory positioning is achieved, the sutures are tied using a slip knot technique to allow the adjustment of centration and tension. Finally, the knots are buried within the scleral grooves to reduce the risk of erosion. The patient did really well post-operatively and is happy with the cosmetic appearance. Case 4 demonstrates a complex anterior segment reconstruction after traumatic injury. After cataract removal and placement of CTS and CTR, now let's assess the iris and see if iris repair was even possible. Iris was carefully opened with viscoelastic and unfolded by microforceps. it was decided to do at least 3 iridodialysis repair followed by pupiloplasty. To repair iridodialysis, 10-O-proline on a long straight needle was used to pass through the iris root and pass through sclera 2 mm away from limbus. 2 suture passes are needed for 1 segment of iridodialysis repair. Slip knot was used and tied for correct tension. This was repeated nasally and superior-temporally to restore iris anatomy. For pupiloplasty, multiple Sipser sliding knot technique was used. This was preferred over pupil cerclage due to potentially pulling detached iris from scleral wall. 10-O-proline on a curved long needle was used. Single pass through iris stroma at the 2 adjacent points of pupil margin, then externalize the needle. Coughlin hook was used to externalize the suture for a single fall-through knot. Same pupiloplasty technique was repeated in 4 other quadrants to achieve a round and centered pupil. Finally, endothermal pupiloplasty was used to cause iris contraction and therefore for better pupil centering. This patient did really well. Best corrected visual acuity at 1 month post-op visit was 20/30. In summary, this video has presented 4 clinical cases demonstrating a wide range of iris reconstruction techniques, covering most common repair scenarios. I hope you find this instructional overview practical and useful for your future cases. Thank you very much for your attention.